Good Friday morning. We are back with another week that has had a lot of things happen, both at the state and at the federal level. So we're going to get started. The first thing I want to talk about is Wisconsin has had two of the grants it thought it was going to get canceled by the federal government. And there's really three things that are noteworthy about this particular situation. We were meeting with the Department of Public Instruction. They're both education grants from the U.S. Department of Education. Both grants are specifically focused on students with disabilities. So I think that's the first piece, is that these are definitely pieces of funding that are supporting either the growing of the special education workforce, which many of you may know needs additional teachers and staff with expertise in it, or a grant that is specifically geared towards helping deaf-blind students with a whole and their families. So that's the first point, is that these are specifically focused on students with disabilities. The second thing that is noteworthy here is these are grants that were awarded a couple years ago and were slated to go through 2028. We've talked a lot about appropriations and federal appropriations in the sense of what is the budget that Congress is approving to be spent. But there's another layer. Oftentimes, Congress will say, here is a lump sum of money agency like the Department of Education, and then the Department of Education awards that funding from that year to states or organizations or other things. But oftentimes, that money that was appropriated, say in 2023, for a specific purpose, doesn't always have to be spent all in that year by the grantee who gets the money. It's very common for federal dollars, people to have 3 or 5 years to spend those federal dollars. So money that maybe Congress approved in a past year may be spent over time. And there's some reason to do that, because especially when you're giving money for, say, a project, it takes time to hire people, to get the project up and running, and to run it for long enough to see whether or not what that money did. So it's very common to have federal grants where the person who gets the entity that gets the money has multiple years, usually 3 or 5 years, to spend it. And that is what happened here. These were both grants that were awarded for a 5-year time period, and they were canceled before they had fully run through that time period. So this was money the state thought it was going to be receiving through September of 2028. And this is money that was awarded a couple years ago before this administration took office. So, that is significant in the sense that this decision affects money that Congress appropriated not just this year, but years ago. The third thing that is noteworthy is why the money appears to have been taken back. And I should note there are appeal processes that our State Department will probably use. Like they are very clearly saying, we have been told this money is gone unless. And I think they will use their appeal processes, but it's not clear that any of this will be undone. So they are definitely approaching it as if this money has been rescinded, even though there's still some process to ask questions about that. The first grant, it appears, and 46 states got a letter that they were going to have this grant canceled. And in that letter, the federal government kind of told them why. And a lot of times, the letter was highlighting various words or pieces of curriculum that the U.S. Department of Education didn't like the way the state had phrased it, and they want the state to change or remove words from curriculum to get the money. That's noteworthy in the sense that states have complete autonomy. They control the curriculum that they hold their educators accountable to. So this again is a very different approach where the federal government is now examining um, really language that they do not have authority to ask people to change or any oversight over, and saying, well, we're going to try and impose what we would like on states and use these grants as a way to try and kind of muscle in and make states make changes. Um, the other thing that is noteworthy is the reason the other grant seems to be canceled is because there were a few key words, transition being one of them, that were highlighted. And transition in the special education world means transition from secondary school into adulthood. Recently, transition has meant, if you are in gender studies, transition from male to female or female to male, depending. And that seems to be, what they believed this grant was more focused on. It is also another item that was noted is some language that was, talking about how the effort to hire a diverse group of coaches based on gender and race. Again, that has been fairly common language in the past, but in this context, it looks like it was flagged as and labeled DEI as something that the federal government said, no, we think you're setting up this grant to give certain kinds of people an advantage in the hiring process. So those are kind of the three things that are of note in this particular situation. I happen to ask, are there any other grants that you're worried about? And I think that the answer is, if we're looking back to money that's already been awarded in years past, really any and every federal grant is vulnerable to this kind of approach of retroactively looking to cancel money that has already been awarded. So a question you can ask your congressman is, what are they going to do about it? It is very hard for agencies and state budgets and organizations to plan and continue to operate if the money that they are receiving is in fact not guaranteed and could be changed at any time. So that is a question that is relevant now for Congress. Some additional news. For a long time, viewers of this webinar, this is not new news. Our Medicaid director is now saying publicly what you have heard from us before, that the deadline for implementing the Medicaid prove you're working or exempt requirements really is going to, in effect, going to be January 1st, 2027. And I think what's noteworthy here is two things. First of all, our Medicaid director is now saying this publicly. He said it at a conference, and then it is being reported by one of our favorite nerd publications, Wisconsin Health News. So this is now a message that is being sent out to people who are in the healthcare business and world. It's not a different message. It's just being said very publicly now. And I think the second noteworthy piece here, which we have not talked about a lot, but is true, the Medicaid directors are really trying to push the Centers for Medicaid Services to make sure that the work requirements that are being required for Medicaid and the work requirements that are being required for SNAP. Remember, the reconciliation bill changed the existing work requirements for SNAP and made them harder, and then added work requirements for Medicaid that don't exist. So there are definitely definitely an advantage for those requirements in both programs to be as similar or identical as possible, because many people who are in Medicaid are also using SNAP. About 2/3 of Wisconsinites in SNAP are also in Medicaid. USDA on their website says it will have guidance September 30th. There is no indication of when CMS will put forward guidance. They have, under the law, until June of 2026 to do that. I was on a webinar yesterday afternoon where there was a person from CMS talking about, implementation of work requirements, and the language that our Medicaid director is delivering publicly here, where CMS has kind of told states, do things without our guidance, came through in that speech as well. What she said at that time is there do seem to be, CMS is saying there are some very clear pieces where there aren't any exceptions, and the DHHS secretary doesn't have any discretion. So you states can get started on moving forward with your planning in those places where there really aren't any options. And then she said, there are some places where states do have options. And you can start those debates about what to do now. Now, notice the word debate is not the same thing as making decisions, right? So there is this world of places where states can make different decisions. And I think that's what Medicaid directors are worried about. They don't want to make decisions now that CMS later says are not the right decisions to have made. And then the third thing she said is, we are going to be setting this, submitting guidance at some point, and we are going to put in that guidance language that is intended to steer how states on some parts of the law that they have discretion on. Again, that is one of the things Medicaid directors are worried about. What if we make a decision and the decision we make is out of, is not the same as what the guidance says? And she then claimed they were going to try and issue guidance that was going to be relevant on really key policy decisions and things that would impact how states govern their IT system changes. So we're less than 15 months away from when these requirements would have to be live and working. Another thing we haven't talked about much is, January 1st, 2027, everything has to be live, but there are also requirements in the law that you have to talk to people who need to do and need to be trained on how to complete these requirements before that implementation date comes. So one other thing to think about as we keep going over the coming months on what are these requirements going to look like is that, starting next September is going to be when states are going to be required to start communicating with Medicaid members about what these requirements are and what they're going to have to do. And that does shrink the window for actually making decisions and having the technology ready to go live on January 1st even further. I'm going to focus a little bit on a bill that passed yesterday, the state assembly. And the reason we're focusing on it a little bit is because it is very similar to some of the approaches that we have seen from the federal government take. Some weeks ago, you might remember and Wisconsin is in an ongoing lawsuit on this particular piece. There was a change in policy that the Federal Department of Health and Human Services made that essentially added on to the list of public benefit programs that lawfully present immigrants and others can't access. And one of the things that they added into that list of things, again, it's just a policy that they're changing, was federally qualified health centers. And there were a lot of people who were very concerned that if you were all of a sudden saying, if you're of a certain immigration status, this is now considered a public benefit and you can't access it because of that status. There were a lot of questions that were being raised about, well, what does that mean for entities that serve populations without knowing their immigration status and do so on an emergency or other healthcare basis, where, trying to assess who has the right status might interfere or prevent somebody from getting healthcare. So that idea of, adding a healthcare related funded entity to a list of what is a public benefit and then deciding who can or cannot access those benefits is something that has been approached at the federal level. This is somewhat similar, this bill. And it really is, this is the entirety of the bill that is pasted into this slide here. It really is trying to say only people who are lawfully here can have, health care paid for, essentially. That's not articulate the way I just said it, but essentially what the bill says is that if you are, and if state dollars pay for part of the health insurance or the benefit program that provides health care, then if you are not lawfully present, that money can't be used to pay for your health care. Now, this is somewhat in conflict with federal law, which requires states to provide emergency medical care to anybody and without citizenship or immigration status. And we pay, there's relatively little money that goes into that. It's also worth noting that, state funds that help match and contribute to Medicaid and CHIP and sometimes the AKC marketplace, like already people who are not lawfully present in this country cannot get into those programs. It's also worth noting that if you are a state or county or local employee who has health insurance through those governmental units, and likely there is some state funding that is helping contribute to that insurance plan, well, all of those employers, those public sector employers, are generally required to document people who are legally authorized to work. So, is this bill addressing a problem where there are people who are not legally here who are accessing healthcare that has some touch point to state dollars? I question that. There are some people who are lawfully present who may qualify for Medicaid or CHIP. So it is unclear, but like that is something that can happen. But there aren't very many, there aren't undocumented people who are ending up in Medicaid. And the testimony that the bill author gave kind of gave the impression that that was the case. And it is not. So why are we bothering to talk about this bill? I've already said it's somewhat parallel to some of the policies we see the federal government doing. But I think that this is another example of you may be trying to target a particular policy to one group, and that isn't going to work. You are going to end up targeting more people than you think. We've talked about that, with regard to Medicaid prove you're working and exempt requirements. All the way through since January, part of the message the disability community has been saying is, you can't choose who you want to protect and who you want to hurt. It is not going to work out that way in practice. You are going to end up making a policy change that is going to catch a lot of people that you don't expect in the process. And I think this is another example where, yes, you might be trying to target, people who are not lawfully present in the country. We'll set aside how many of those people are actually even getting any type of health care that has a state dollar touching it. I think that there's reason to question that. But the reality is that if being lawfully present here or a citizen is now what you have to prove before you get health care, that means that any potential patient would have to prove that they're not undocumented. And certainly that can be, difficult, especially in an emergency situation, or where they don't have access to the paperwork. And speaking of paperwork, the bill's totally silent on how healthcare providers should check people's legal status. It doesn't say what counts as proof. It doesn't give you a timeline. Do you have to have that before you give care? Do you have to prove it afterwards when you're getting reimbursed? What happens if there's a mistake? And the penalty, there isn't one in the bill, except that it implies healthcare providers won't be paid, or potentially that money will be taken back if somebody they treat turns out to be undocumented. So again, this is an example of, a policy that looks like it's supposed to be directed to a very specific group of people that actually has pretty big implications for everyone, which is really the same theme that we see when we're making changes to Medicaid as a whole and SNAP. It is the same idea that you can try and target individual people, but that isn't how it works in practice. And there was some coverage of it. Some of you may be familiar with Kids Forward, that does a lot of advocacy, especially for children and families, and Medicaid. And, here's this person says the same thing. If you're creating a situation where you're prohibiting funding for people that aren't unlawfully present, you're creating a need for people to verify their status to receive health care. It happens that a different Wisconsin news outlet did a fact check on are there unauthorized people receiving health benefits, the same week this bill came out, and the answer is no. We've covered that multiple times across the months, but it just so happens that the rationale for the state bill was directly refuted in the press at the same week. So why are we talking about this bill? In the fall and before elections, you start to see a lot of bills that are introduced, and some of them may be introduced, that have been introduced before in previous sessions. Federal and state lawmakers often introduce bills they know are not going to pass, right? They know that even though this particular bill passed the assembly, I think there's some level of confidence that our governor would not sign it into law. In other words, it would be vetoed and it wouldn't become law. So there's a lot of freedom for lawmakers to kind of launch out bills that they know won't become law as a strategy to message to potential voters. Here are things we think are good ideas, or things we think you're going to like as a voter, to remind you of who we are, and that and give us something to talk about with you. So both parties do this, and it's a strategy to show their base folks, the folks that they believe will have voted for them before and will vote for them again. It's kind of a reminder of here's why you like me, and here's why you should show up for me next November. But the thing is, ideas that start off as messaging bills sometimes get momentum, or if they are unchallenged, people kind of get lazy. They just keep reintroducing them, and the world changes. So, a bill that started off as a messaging bill that's introduced 5 times over 10 years and nobody thinks it's going to pass, all of a sudden it might end up being in a situation where it could pass and be signed into law. And people kind of get lulled into, oh, here's this idea I've heard about before, and they don't think about it too hard. So even when it's a bill that isn't probably going to become law, if it's not a good idea, or if it's an idea that has serious unintended consequences, it is an opportunity for advocates and constituents to say, hey, this thing that you think is a good idea actually maybe isn't, and here's why. And this is an opportunity if you want to exercise your muscles with your state lawmakers, that to challenge that assumption, right? That the idea that you have to prove before you get health care whether you are legally in the country is maybe an idea that is hard to administer and could be a real problem for lots of patients, not because they aren't lawfully present, but because administering and figuring that out, especially in a timely way when somebody really needs care, is hard to do. Survival Coalition in the next couple weeks will be having a press event. There's been discussion amongst disability advocates and a lot of concern about kind of the collective themes of a lot of the policy changes at the federal level that we've been talking about, both in the administration and in Congress. And many advocates are really worried that a lot of the progress that we have made in the last 50 years is potentially under threat. So if you are somebody who knows local reporters, we did send out a media advisory. It's a virtual press event. It will be held September 24th, and you can contact Phil at the Survival Coalition email address for a copy of the media advisory to invite reporters that you know. We are still working on our survey data. I have to say I've seen some of the preliminary results. Again, you have 10 days until the deadline. It's September 19th. Our goal is to make a very useful infographic piece that advocates can use with their lawmakers to really show what they're worried about. So this is again a final push to take the survey and make sure other folks in your life have done so as well. All right, Congress. I've added things to the timeline, so it looks a little bit longer. Just this morning, and we'll talk about the likelihood of whether there will be a shutdown or not. Just this morning, there was some breaking news that potentially the U.S. House might vote on a continuing resolution next week. Deadline indicated could be November 20th. And there are some moving pieces. But you can see that September 20th, the September 30th is the end of the fiscal year. They have to do something before that date. Otherwise, we are looking at a federal government shutdown. And you can also see that there is a recess that Congress takes the week of the September 22nd to the 26th. So really, next week is a critical week for action because if they don't do anything next week, they only have 2 days after they come back from their recess to do something before we reach the end of the federal fiscal year. You may also remember that we had a second pocket rescissions bill introduced. Congress has not taken any action on that, so that's just kind of sitting there waiting for the clock to run out at this point. There's been a lot of discussion in the news about, will there be a shutdown or not, or what should people negotiate as part of a funding deal. We'll talk about that in a minute, but you can see that we're getting more and more little data points about all of the things that need to happen by the end of the year. Just a reminder, some of these things are ongoing and might be, ongoing ways or strategies that could change federal funding levels no matter what is passed in the federal budget. The good news, because we should emphasize that, is that the U.S. House and Senate committees really do agree on disability program funding. Last week, we talked about the House subcommittee having a markup hearing on the Labor, Health and Human Services and Education budget, but we didn't know what was in the budget tables. Those tables are the actual appropriations by program. And so there was a little bit of hedging on our part saying, well, this looks pretty similar to what the Senate version of the same bill did, but we don't have proof because we haven't seen the tables. Well, the tables came out this week, and it does look like funding for, again, all of the things that are under ACE, or many of the things that are under the Administration for Community Living, are the same funding levels as we have now, and they are the same as what the Senate has proposed. And that's a pretty big deal, because I think there were a lot of national disability advocates that were concerned that the House might have very different ideas about what to fund, especially in the Health and Human Services Agency, than the Senate. And it looks like there's agreement there. It's a good sign. On the other hand, this bill hasn't passed the full House or Senate yet. If you want to read what is, in that budget appropriation bill, including everything for the Department of Health and Human Services, I have the link below here. If you're interested in the disability and aging programs under the Administration for Community Living, there's a page reference so you can go straight to what is there. So will there be a shutdown or not? There's kind of three different camps, two of them in Congress and one of them in the administration. There are definitely members of the Republican House who do not want to pass a funding bill. They don't want a short-term deadline. Because they are worried that if you pass a continuing resolution that has, another deadline very close to where we are now, that puts some pressure on negotiations, and you might end up with a bill that funds the government for a longer period of time. Remember, the fiscal hawks are a group of people who are really worried about the amount of money that the government is spending and what the government is doing. They would like to see the government do fewer things, and they would like to see it cost less. So they are kind of aligned with the idea of cutting or finding other things that to reduce in the federal budget. Of note, repeatedly having new deadlines to pass funding bills is, again, a strategy from the Office of Management Budget person to kind of continually, create new opportunities to cut spending. So there's some alignment with perhaps fans of reducing the federal funding that are in the administration and in Congress using that approach. So that, if you ended up having a multiple deadlines to keep deciding the same things. What should we do for, what should we fund for this federal fiscal year? Many watchers think that that would let the administration use rescissions and reconciliation to kind of add or subtract funding, and they could do that entirely without relying on any support from the Democratic members. So that's kind of one faction. Now, there are Democrats and also Republican leadership who would prefer a continuing resolution be passed to fund what we're doing now through November or December. And they want to set up that short-term spending deadline because they think it will give them more time to negotiate spending that both parties can agree upon for the whole full year. Democrats have been saying that they will not help the Republicans pass a budget. In other words, force the Republicans to have to vote with only their members. And in the Senate, that is not possible because they need 60 members to vote for the budget. So they actually need Democratic votes to pass the budget in the Senate. That's not true in the House. They have a now narrower majority of 2 seats in the House. So you can pass a budget in the House with only Republican votes, but you can't do that in the Senate. And so there is some, opportunity for Democrats to say, hey, you need us in the Senate to pass this budget. So that means we should get something out of it. They haven't been clear about what that list of demands might be, but it is a point of leverage that they have at the moment. However, some watchers say, with the use of rescissions bills and stopping of funding and impoundment that we've seen the last year used by the administration, could you negotiate in good faith and have those items that you fight really hard to get into the budget just be undone or not funded if given the behavior that we've seen in the last 9 months from the administration. This morning, it looks like that this idea of, really fighting before September 30th to get something done is not going to happen. The House and Senate leaders think they have agreement on funding for 3 of the 12 appropriation bills, and they're some of the smaller bills: agriculture, military construction, the legislative branch. And the latest is that maybe they will pass those bills, so those agencies are funded for the full year, and then pass a clean continuing resolution for all of the other things the federal government does until they can come to an agreement. A clean continuing resolution means that there are no adjustments to the funding levels. It is essentially we are doing things exactly the same. So when I had in that table a couple slides ago that November 20th is a potential deadline, that is the current thought from the House of where should we move instead of September 30th, where should the next deadline be to give ourselves time to come up with a full budget? They want to do about a month, right, until November 20th. So that kind of means that the Democrats are going to be put in a position potentially of, do you shut down the government now? Do you not shut it down? Do you vote to pass a clean CR and these appropriations for these 3 agencies that seem to not be, where there's not a lot of disagreement? That's all something that the Democrats are going to have to figure out in the next few days. The White House, however, is definitely in the camp of wanting a longer term deadline. And It is important to note that January 31st is after December 31st, which is when the ACA subsidies expire. And it's also after, Congress would have had to make decisions to avoid sequestration. We've talked about sequestration a couple of times. The bill, the HR 1, the reconciliation bill that was signed into law in July 4th, made enough of an increase in the deficit that it triggers a different law that requires automatic across-the-board spending cuts, including for Medicare. It would require about a 4% or $500 billion cut for Medicare unless Congress decides to do something different. So for watchers, that January 31st date is important because it is beyond the deadline for a couple other big things that Congress would need to do if they want to avoid either cost increases for ACA marketplace policyholders or across-the-board cuts for Medicare and many other federal programs. This week, the White House also gave a 21-page list of items that they would like Congress to fund at a different level. So when we talk about a clean CR, that means funding things at exactly the same level. The White House says, well, there's some things we want you to fund at different levels, which is not a clean CR. And obviously the White House is also thinking about, what are the opportunities if a shutdown occurs that does give the administration a lot more flexibility to determine what money is spent or not during a shutdown period. So it is, not without risk that if Congress fails to tell the administration how to spend funding, and funding is, they no longer have authority to spend money, then the administration gets some additional flexibilities to figure out what to do in that time period. So what could lawmakers ask or constituents ask to be included in a final 2026 budget? There's a lot of discussion about, well, if you're actually going to negotiate, you're going to prioritize Democrats and Republicans coming together to create a budget where both sides are getting things that they want. Because remember, in the Senate, you have to have 60 votes, which needs to include Democrats. How do you use that leverage and what do you ask be included in that budget? And here's just a list of various ideas that you could suggest to your members of Congress or that might be opportunities. Of this list, not a lot has been discussed publicly, except for maybe we should think about extending the ACA marketplace subsidies. And there's a pretty long article about why the subsidies are the thing that members from both sides of the aisle are talking about. Whether or not one party decides to shut down the government often is a political decision about who gets the blame or the credit for what happens next. So you and I know that these expiring subsidies at the end of this year are a really big deal. For the average person, their costs are going to go up 75% if that doesn't happen. However, even if the subsidies are extended, healthcare costs in general, plus some changes from the reconciliation bill that impact the Affordable Care Act marketplace and potentially tariffs and other things, those are also factors in costs going up. So, when you are hearing about the ACA subsidies, part of the calculation that folks are making is, do people in the public know that their costs are going to go up? You are amongst the top 99% of people in this country who know what's going on. Nobody knows more than you guys. That isn't true for most of the rest of us. So if you're going to fall on your sword and say, this is the thing that we are doing, and if we win this, it's really important. It is important if people know that what you've done has helped them and by how much. Um, there's also debate about how long to extend the subsidies. Is it worth it to delay the pain for another year? Should you fight for permanently extending the subsidies? There are some Republicans who support extensions, others are really opposed. So this is not a sure thing at all. And a lot of the calculation is going to be about whether potential voters will give Democrats or anybody else credit for a less high price than they would have paid. It's also noteworthy that, there's a focus on the ACA marketplace, and there are 20 million people in the marketplace, including people with disabilities and older adults. And the focus is on this aspect of the healthcare cuts. There's been less focus on ratcheting back the cuts to people in Medicaid. Just an observation. We'll see next week how likely it is that there is a shutdown. Most watchers are expecting a clean CR, and I think that the opinion is really divided about whether those subsidies will be extended at all. There are some slowdowns, though, on the idea of a second reconciliation bill. Over the summer, there were lots of committee meetings and other things in the House of trying to figure out, what would you put in to another reconciliation bill? Again, a reconciliation bill is noteworthy because it requires a lot fewer votes to pass. So it has become a vehicle for lots of big policy because it requires fewer people to agree to do it. So they're still going through the motions and having members submit ideas of what to be included. But the scuttle among leaders is there really feels like less of an urgency this time than there did the last time about a reconciliation bill. Remember, in the spring, one of the big things that Congress had to deal with was raising the debt ceiling. And that provided, again, a really distinct point in time where if Congress didn't act by a certain date, then that would trigger other things happening, mainly that the US government wouldn't be paying its bills, which we've taken very seriously in this country over the last few years. So there isn't that kind of urgent deadline that if Congress doesn't act by a certain date, it triggers other things to happen. And a lot of watchers are saying, well, that really is taking the wind out of the sails of a second reconciliation bill, at least in the fall, because we have other things that do have some urgency that Congress needs to do, such as the federal budget, such as are you going to extend AC marketplace subsidies before they expire, such as are you going to prevent sequestration cuts from going through. All of those things have to be decided really before December 18th. Moving to the administration, we're going to go through this quite quickly, but I wanted to make sure that you had some links to the articles. Last week, Secretary Robert F. Kennedy had a hearing before the U.S. Senate committee. You might remember the week before the hearing, there was a lot of upheaval at the Centers for Disease Control over vaccine policy, and a number of leaders at the CDC either were fired or resigned. So a lot of coverage of that particular hearing, and you can watch that hearing in front of the Finance Committee. The link is there. Overall, the coverage of that hearing said there were lots of pieces where what the secretary was saying was not true or partially true or not responsive to the questions that the committee asked. There continues to be coverage of this forthcoming report on autism that is supposedly going to identify the cause of autism. During a cabinet meeting last month, the secretary stated, "Oh, we know what the causes are. We're finding interventions that are clearly causing autism." And this is making a lot of autism researchers pretty nervous because the report that's supposed to be identifying causes for autism is coming out before any of the autism research that has been being funded for years is being awarded. So there have been some leaked reports about what might be in that report. The Wall Street Journal reported that this autism report might identify acetaminophen, which is common an over-the-counter pain reliever and fever reducer. Often the commercial brand is Tylenol, that ties acetaminophen use during pregnancy as a cause of autism. Folate was also mentioned as a potential item that would be included in this report. It is noteworthy because Tylenol is acetaminophen is one of the most studied medications there is, and it's the most widely used drug in pregnancy. So there's a lot of research that has been done to confirm that the use of this drug is safe for people who are pregnant. And a lot of scientists were really looking at that as they were really worried about that association being, publicly put out there, which runs counter to all of the existing research that has been in there. Scientists are also worried that there are going to be causes for autism identified in this report that may or may not have any scientific backing, and that there is an effort to identify a few things as being causal when most scientists overwhelmingly agree that autism is the result of many different factors coming together. In fact, the Autism Science Foundation was concerned enough about the report, the story that the Wall Street Journal ran, that it issued a response statement, saying, "Hey, there isn't a single cause, and there's no reason to think that folate levels or acetaminophen are in any way related." Of note, also, the idea that that somehow something that the mother exclusively is doing is a cause is something that I pick up on because, in the 90s and earlier, certainly there was a lot of scrutiny about, what mothers were doing that might be the cause of autism. And as we know, autism is not solely the result of parenting or one parent only. It's a very complex condition. So it's kind of an old idea to look for, one cause and also find one parent to blame for that cause. Other articles have also said that they're expecting vaccines again will be linked as a cause to autism. There's been a huge body of research over several decades that has really debunked a link between vaccines and autism. This time, it seems the link that's being proposed is again another additive used in some vaccines. Thimerosal was kind of implicated and debunked years ago. This is a different additive, so it's really a different way to get at the same idea that somehow vaccines are causal of autism. And to the best of our knowledge, there's great agreement among scientists that that is not true, and a lot of research to support it. There was a report released this week that is not the autism report. This is a Make America Healthy Again report that, again, does seem to confirm some of the reporting over the last several months that prioritizing bad reactions to vaccines, um, and autism and causes of autism is something that the department will want to really focus on. Um, a couple of times we've covered the idea that the National Institutes of Health is going to be using a whole bunch of data, personal data about people. It is unclear if that is going to be mined from existing databases, or it looks like some of these sources might be, in third-party companies, but that idea keeps coming up, and is now in this 20-page report. Additionally, the Centers for Medicaid Services is specifically looking at payments covering healthcare for immigrants within certain states. So the idea of Medicaid data being used to specifically assess whether states are spending the dollars correctly is happening, and it is not universal. It seems to only be certain states. Um, and, there are states that have established programs that use state money to cover people who may have unknown immigration status. And it appears that this particular policy is targeting only states with full Medicaid coverage for both adults, kids and adults without legal status. So that is not Wisconsin, but it is states like California, and I think there's like half a dozen that have made the decision that they're not using Medicaid dollars to cover people with unknown documentation status, but they are using state funding to do so. The White House is also saying that it does plan to revise an administrative rule that was passed in the Biden era. We've talked about this a couple of times, but it looks like we're getting closer to the point where perhaps they're going to actually start the public comment process. Again, as a strategy, it is similar to some of the other strategies we've seen from the administration. This would essentially remove SNAP from the list of items that are considered public assistance. So, in other words, it would mean that people, when you readjust and make the list of public assistance programs smaller or narrower, it also means that you can essentially adjust who qualifies for the programs and what that means without really making many changes. So the change that they're thinking about doing here is basically what public assistance programs should be counted when determining whether SSI beneficiaries who live with people who might be providing some in-kind support, how much should we cut those beneficiaries' benefits? And if you live with people who are receiving this certain list of public benefits, then you don't have your beneficiary check docked. They're talking about removing one of the more common benefits, which is SNAP, which means about 300,000 people or more will all of a sudden have benefits docked that don't have them docked now. So it is unclear when there will be a public comment period on the rule, but this is kind of the second time this has come up in the last few months. So we kind of anticipate that this rule will be forthcoming, and it will be another opportunity for advocates to talk about what that would mean. If you had, more people who were subject to about a third of their SSI benefits being withheld just because they live with somebody who is presumed to provide in-kind support. I'm going to skip this article. For those of you who want weekend reading, this can go on your list. Essentially, there are lots of reasonable things that are problems and challenges that many SSI beneficiaries would like to see solved, and the work that DOJ did and continues to do, because now some of those people are actually hired in positions, did not solve the issues that most people think are important to solve. I'm going to spend a little time on this. We are continuing now to see more and more states react to federal funding cuts, both from the reconciliation bill that passed in July and also from some of the federal funding cuts that happened in March, or money that has been withheld. So the administration has reduced some funding outside of Congress, which is the subject of a lot of litigation. And then there are changes that are occurring as part of this reconciliation bill that will also mean either less federal money coming to states or more costs that states have to pick up that they're not covering now. So the first kind of wave is $11 billion in cuts that were made administratively. Lots of them in public health and mental health, and also National Institutes of Health grants. Those are a lot of research grants. A lot of that money was cut in the spring this year, and now states are trying to figure out, okay, what is the loss that we are expecting, and how do we deal with that in our budget? So there have definitely been states that, because of those administrative cuts, have been making changes to their budgets. And you can see there have been a variety of approaches that for states, responding to cuts that are unrelated to HR 1 or the reconciliation bill. In some cases, states have decided to put more money into things that the federal government no longer funds. Sometimes they are postponing, big capital projects so they don't have to spend money. Sometimes they're making requests to the state legislature for more funding to kind of shore up money that has been lost. There are also lots of states who are trying to figure out how much the cuts in HR 1 are going to cost them. Some of which start right now, those USDA, the SNAP work requirements, for example, and some of those changes to SNAP are going to occur within the next few weeks, and others that are coming over the next few years and perhaps will impact not only the current budget, but several budgets down the line. So some of the states are figuring out, especially with the Medicaid funding, what does it really mean, the HR 1 funding cuts? And you can see that there are states that are really going to have big holes given the changes in the HR 1 bill. And some states are trying to get ahead of that, and our state was one. We passed a budget very hastily got it under the wire before the law changed at the federal level, to try and at least lock in that we had enough money to keep running Medicaid as it is now for the next 2 years. But certainly there are states that are having to make changes before that. North Carolina is one of them. They are actively cutting their Medicaid spending effective October 1st. Some of that isn't because of the reconciliation bill. It's because they did not continue, their state legislature didn't pass the cost to continue to operate their Medicaid program as it is. So it's almost like they are preemptively cutting their program before they have to make even bigger cuts. So in this case, it's an across-the-board rate reduction, again, for providers, which is also what Colorado chose to do. And for some services, it's an even steeper cut, 8 to 10%. And those 8 to 10% cuts include things that are used and disproportionately used by people with disabilities. North Carolina's Medicaid leadership has been pretty clear with its legislators that these kinds of cuts may cause their existing providers to accept fewer Medicaid patients or stop and accepting Medicaid patients entirely. And there are certainly provider organizations that might not be able to weather those kinds of rate cuts that might go out of business. Also of note, it isn't only providers that are getting these cuts. It also means that the State Department of Health Services in North Carolina will be doing fewer things to make sure that people are getting the services that they are eligible for and that those services are quality. Another article from North Carolina. This one is noteworthy because as you read the article, it's really talking about what these kinds of rate cuts could mean to institutional services. The services they're talking about in the article are for facilities regulated as IDDs. So in our state, that would be the state centers, and also residential placements, which are more along group homes. And as we know, institutional services are mandatory. However, this article is pointing out, they also rely on good Medicaid rates in order to pay their staff enough. So even folks where the services are mandatory may be impacted in the sense that, regulated facilities like DD centers and like nursing homes do require a certain number of qualified staff to be able to run themselves. In other words, they can't take everybody who needs their care if they don't have enough care workers to provide that care. So it is another thing that perhaps hasn't been on the front of our mind. Obviously we are very concerned about optional services like home and community-based services being the first place that absorbs cuts. But even things that are mandatory services, if you don't have enough staffing, the number of people who can be served declines because there aren't enough people to safely conduct and run those services. New Mexico is trying a different approach. They are looking to increase parts of their budget to try and offset what they know is going to happen at the federal level. New Mexico has the most number of residents enrolled in Medicaid of any state. And it's, as a relatively low income state, that $1 billion loss in funds is pretty big. It's pretty significant. Another example of fallout from the reconciliation bill. And again, it's another, kind of proof in the pudding that, Congress may have not wanted to target children, but ultimately the cuts that are being made are going to impact the quality of care for children, especially in places that, serve a lot of kids or have kids that require pretty significant interventions. So children's hospitals are kind of raising their hand and saying, hey, we're going to lose a lot of money because of this bill, because a lot of what we do is for complex kids who are on Medicaid. About half the revenue for a lot of children's hospitals comes from Medicaid. So this bill makes a big difference for those entities. We've talked a lot about rural hospitals serving more Medicaid patients than many. That's also true for children's hospitals. And the specific change that they are highlighting from HR 1 is not necessarily the one that we've been focused on the most. This is again about state-directed payments, which essentially tries to make sure that states aren't paying too much above the Medicare rates for Medicaid patients. It's kind of bringing some of the higher rates down to a Medicare rate. And the reason why states have chosen to provide higher rates to serve Medicaid patients is to make sure there's enough money to cover the costs of those services and to encourage providers to take those patients. So the current, the former administration had allowed states to pay up to what a commercial insurance plan would pay for those services, which is about 2.5 times more than the Medicare rate. So when you start to think about, ooh, you're coming down, that's a huge reduction. If you have to come down to pretty close to the Medicare rate for services where you'd been paying 250% above that Medicare rate. In our state, we're a non-expansion state. That provision says states like ours can pay up to 110% of the Medicare rate, but it's still a pretty big reduction over time. And that change is in the bill is supposed to start taking effect in 2028. There's some indications that CMS may be looking at seeing whether that states have to do that even earlier. Again, another article about just what will happen to hospitals and other care facilities that are taking care of more patients with Medicaid when those cuts happen. This is not necessarily new news, but if you're looking for additional things to share, this is another example of what that change in state-directed payments, that ratcheting down of what the Medicaid rates are down to Medicare rates will mean for the 41 states that do that. And the last slide, again, we've talked about this before, but in a separate article is saying, hey, even if you're privately insured, expect some pretty big increases to healthcare costs. And one of the reasons that private insurance healthcare costs are going to go up are these policy changes that we've been talking about since February. Those items that were in HR 1 that make Medicaid cuts and changes to the ACA marketplace plans are going to mean there's less money to cover the costs hospitals have and other providers. And frequently what happens is if there's less ability for other payer sources to cover those costs, it means that insurers and hospitals will turn to the payers who are left, which in this case means the privately insured. There's really 4 main payers of healthcare. One of them is Medicaid, Medicare, which is the biggest payer, the Affordable Care Act marketplace exchanges, and privately employer-sponsored private insurance. So the HR 1 directly impacts Medicaid and the ACA marketplace, and it could impact Medicare, especially if sequestration goes into effect. So you have 3 out of the 4 payer sources that cover the cost of healthcare potentially impacted by this one bill. And that is going to mean there is a lot fewer places to go to cover the costs. So employers and employer-sponsored plans are one of the last places to go. And it may mean that even if you are privately insured or your employer pays for your insurance, yes, your premiums will go up. You may have more out-of-pocket costs that you could have to cover. And employers are going to be looking at plans that cover less, which again, in turn, means that less of those costs are covered and you, the consumer, are ending up being impacted by bigger bills. Okay, so that was this week. Are there any questions that haven't been answered, Sally?
Nope, everything's been answered. We're good to go. questions were just, there was a question about the education stuff and whether it affects maintenance of effort. And